Hi, so our group chose to focus on patient-initiated violence within the healthcare setting. So a specific subset of workplace violence, focusing on that coming from patients within the healthcare setting. And so we'll talk about what the issue is and talk about definitions, discuss who are affected, particularly the health and economic effects of workplace violence in the healthcare setting, talk about some proposed solutions as well as a little bit on current events. And so what is the issue? And starting with the definition from the National Institute for Occupational Safety and Health, which defines workplace violence as anything that includes violent acts, both physical assaults as well as threats of assault directed towards a person at work or on duty. And obviously we can apply this then to the healthcare setting. There's a variety of types of workplace violence defining perpetrators. And so the perpetrator could, of course, be someone who has no connection with the organization or employee. The perpetrator may have a connection with the organization, may not have a connection with the organization, but have one with a particular employee. Perpetrator, of course, could be a current or former employee of the organization. And finally, the fourth category, which is by far the most common, representing greater than 90% of workplace violence events, is when the perpetrator is the patient or customer of the organization or has a relationship with the employee in particular. Some statistics about patient-initiated violence from a study published in the New England Journal of Medicine in 2016. Of course, we would expect nurses to be frequently affected, and 46% of nurses reported experiencing workplace violence in just their last 5 shifts. All ER nurses reported verbal assault, and 82% reported physical assault within the last year. Nursing home aides also frequently affected, and nearly 60% reported physical assault on a weekly basis. Physicians within the ER, more than 3/4 reported being victims of workplace violence within the past year. And among pediatric residents, 1/3 reported being assaulted by patients or family members within their 3 years of training. And personally, I can say that, with thinking about that definition of violence, I would have answered no initially. But now, knowing that violence really can be a bit broader of a definition, I wasn't physically assaulted, but I was certainly verbally abused by family members during my training. And then the psychiatric setting, another area at risk for violence, and certainly very frequent verbal conflict, nearly 100% of the time among staff members in a psychiatric hospital, and physical assault at about 70%. Unfortunately, there's a significant problem of underreporting within violence in the healthcare setting. And some of this comes from the culture. Of course, healthcare workers see themselves as doing a good job and being very benevolent, and not wanting to report something because they feel that it's their job to simply take whatever the patients give them because they're there to provide care. As I mentioned before, of course, what types of events constitute violence, so not having an understanding of the definition among healthcare workers is a problem. And there's a fear of reporting, certainly fear of retribution, as well as not wanting to get involved with the legal system, and potentially that reporting violence could be an issue as it could affect patient or customer satisfaction, which is gaining, of course, increasing importance within healthcare today. What settings are at particular risk for violence within the healthcare setting? And it's important for us to think about the variety of types of healthcare facilities. Of course, inpatient hospitals with their emergency departments come first to mind, but there are also residential treatment facilities, including nursing homes, long-term care facilities, and there are a variety of non-residential treatment facilities as well. Of course, a local neighborhood clinic, perhaps a mental health center, and then community-based care that could be centered around a community health center or residential treatment in the community, as well as group homes. And finally, an important area that we might not think about as readily, but those folks working in the field, whether that's home health nurses, public health nurses, or other therapists and social workers who provide care directly in the home, are certainly at risk. Within this setting, some areas, of course, that are more at risk for violence, the emergency department, psychiatric, geriatric, and dementia wards, as well as the adolescent ward, all related, of course, to the nature of the patients that they're caring for, who might not be as in control and more prone to violence for a variety of reasons. And then alcohol and drug treatment facilities, of course, also at significant risk for a variety of reasons, and of course, certainly receiving increasing attention today given the recent opioid crisis. Specific populations of workers that are at risk include those with the most direct patient care, so nurses and nursing aides, safety personnel, of course, who will be on the front line, or maybe first responders, so security guards and emergency response staff, and anyone with one-on-one patient interaction, and that, of course, can include therapists who are providing direct hands-on care, as well as home health workers. Some of the risk factors, and of course there is a long list and a variety of those, but certainly the emergency room is used for criminal holds prior to going to jail after getting a medical evaluation. Drugs and money are readily available within the healthcare facility, though usually fairly well protected. But healthcare facilities often are very open and unrestricted for patients and visitors to be able to move freely. And of course, people in these settings are going through a variety of difficult situations. They may have had a recent trauma or be particularly frustrated and not acting the way they normally would. At night, particularly in an inpatient setting, there's often very low staffing, which of course is a risk for violence. Many people are working in isolated situations, of course, and as we will talk more about, staff often are not trained to recognize or deal with hostile or escalating behavior. In the emergency department, of course, many facilities have long wait times, and some do also have handguns and dangerous weapons that could be prevalent within the facility. All of this leads to a variety of health and economic effects, which are really significant and important for us to consider. So we mentioned before that the majority of violence was in the one group that had a relationship with the institution, and here talking specifically about healthcare worker injuries that resulted in time away from work. 80% of those events were perpetrated by a patient, and you can see the other persons involved in the diagram here. And all of that can lead to, of course, caregiver fatigue and burnout, stress and anxiety, depending on the nature of the event, and chronicity, depression, and PTSD are certainly a factor. And if that leads employees and caregivers to feel unsafe within the workplace. All of this can lead to significant effects, not only increased medical costs for the person involved or the facility in the form of premiums and treatment costs, but also time away from work, which leads to staff shortages, which really creates a vicious cycle that puts stress on other employees, affects patient satisfaction, which can affect reimbursement rates, and then job satisfaction can suffer among a variety of employees, all leading to greater turnover and continuing to feed this unfortunate cycle. Today, of course, we can imagine that this is a focus of different stories in the media, and the World Health Organization, of course, is involved and has developed a framework of guidelines for folks to use in the healthcare setting. One study done in Chicago showed an increase in violence over the last 3 years, and another study looking at just simply comparing workplace injuries affecting healthcare workers only 20% of the time, but assaults affecting healthcare workers disproportionately greater than 50% of the time. And there are new regulations, so this is an issue that is slowly being addressed. California has passed new regulations, creating the Cal-OSHA standard that defined workplace violence as a supplement to OSHA's general duty clause, and some efforts to make any violence against a healthcare worker considered a felony may help the issue, but certainly needs greater attention and further work. So what are some potential solutions? And unfortunately, the challenge as we talk about these is that the evidence is often very sparse. There's a lack of baseline statistics to do comparisons, and underreporting, as we've talked about, of course, affects these issues significantly. The variety of healthcare settings that we talk about, of course, are not easily compared, and what works in one setting may not work for another. There are a large number of small studies and essentially case reports of things that have been tried and may have worked in one setting, but not applied or tested in other settings. And there is, of course, a lot of expert opinion, which we're not going to focus on today. Metal detectors is kind of an old intervention that's been studied and not particularly shown to lead to a decrease in violent episodes, but interestingly does make employees and patients feel safer. And of course would have no effect on episodes of violence outside the healthcare facility itself. One hospital in Pennsylvania implemented a code green response team in 2013 that included a variety of personnel that was trained in using less restrictive measures, including verbal de-escalation. And looking 1 year after the implementation of the code green response team, they noticed that 85% of these calls did result in a successful resolution, but not necessarily data to support a clear decrease in violent events, but certainly a positive and encouraging outcome. A quality improvement project in an Ohio hospital in 2015 used the Plan, Do, Study, Act rapid intervention process that used universal precautions similar to what we would use to prevent infection. They had team meetings, bedside handoffs, and leadership rounds, which resulted in a 65% reduction in staff injuries. Another very interesting pilot study in 2009 used violence prevention community meetings in the psychiatric setting, including nurses and patients. And one of the things they talked about in particular was really defining violence and simply what was not acceptable. And this led to a reduction in violent incidents by 85%. So certainly encouraging within this setting. One tool that's important to consider and keep in mind for anyone looking at doing something about healthcare violence is the OSHA document, Preventing Workplace Violence, the roadmap that was published in 2015. And it has a variety of examples from different facilities that they group into 5 important categories with more details under each. And so it's important, of course, for us to think about management and employee and participation in these interventions, analysis within the worksite of hazard identification, preventing and controlling these hazards, training, of course, for personnel, and ultimately, of course, record keeping and program evaluation being so important. So really an important resource for folks. So finally, as we think about patient-initiated violence, of course, it is common and likely increasing in the healthcare setting, and perhaps only likely to increase more given the opioid crisis today. The results are, of course, far-reaching and devastating beyond what we might just consider as obvious injury and of course, unfortunate potential fatality, but they lead to burnout and staff and provider turnover, which all have considerable economic impacts. And unfortunately, the culture of acceptance and the benevolent nature of healthcare workers leads to underreporting, and that is a culture that really needs to change. And finally, more data is needed so we can implement evidence-based solutions and bring those more broadly to a variety of healthcare workers, making the important care that is provided safe.